Welcome to the NEI podcast. In today's episode, we're coming to you from the 2023 NEI Congress in Colorado Springs, Colorado. We'll be hearing from one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations.
Hello, my name is Dr. Roger McIntyre, and I'll be answering your questions about my presentation, Unveiling the Therapeutic Potential, Evidence Supporting the Use of Psychedelics for PTSD, Substance Use Disorder, and Other Indications. First question we have, and again, thanks in advance for our colleagues who have been submitting the questions. It's greatly appreciated, and I'm happy to address as many questions as I can. The first one is, do SSRIs enhance or impede the effects of LSD and psilocybin? Great question. The short answer is, we're not sure. The longer answer is that we know that when you take an SSRI for, say, a few weeks or longer, what happens at the receptor level, among other things, is you begin to see a downregulation of the 5-HT2A receptor. Now, how that plays into the story is that we now know that serotonergic psychedelics like the ergoline LSD or the tryptamine psilocybin, among other things, bind to the 5-HT2A receptor. So some people have speculated maybe that might attenuate the efficacy of LSD and or psilocybin if its receptor has been downregulated. That's actually a very interesting thought. It deserves certainly more study and more exploration. There's been some preliminary looks at this, very preliminary. And what's there, looking at some data from a study with psilocybin 25 milligrams in SSRIs, suggests that overall it was well tolerated and didn't seem to attenuate the efficacy. So the first attempt to look at this in a kind of a very thorough way provides a little vote of confidence that we're not seeing a loss of the effect. Also important to state, we did not see serotonin syndrome in that population as well. So in short, more work is needed. There's a theory that maybe we would see attenuated efficacy, but the early data are not aligned with that. More work needs to appear before we will be able to firmly conclude one way or the other. Our next question is, mechanistically, how do psychedelics offer transdiagnostic benefits across multiple disorders, including substance use disorders, and what are the commonalities in their therapeutic effects? I think that question is just fantastic, because what we do know is that treatments for in psychiatry in general are not really specific to any diagnosis. For example, an antipsychotic, of course, can treat psychosis if you have schizophrenia, but it can treat many other conditions like depression or mania and so on and so on. And we have many other examples like that. Rather than seeing psychedelics as treatments that are capable of treating major depression or PTSD or substance use, it's better to see them as treatments that can target domains or dimensions of psychopathology. For example, we now know that early evidence suggests that psychedelics can improve measures of reward or reduce anhedonia. People feel more pleasure in their life. Now, we know that the absence of pleasure, so-called anhedonia, is not specific to major depressive disorder. We see it in many conditions. And if this is able to treat that, then we could say, aha, that might apply to different diagnoses. Another area which is of interest to me and many others is anxiety. Of course, anxiety is the defining feature of an anxiety disorder, but anxiety is seen in many conditions. And that's an abnormal fear response. At the neurobiologic level, many psychedelics have been shown to reduce this exaggerated maladaptive fear response. That then becomes a light bulb moment. In other words, aha, maybe we can apply them to other disorders that share in common anxiety. So in short, psychedelics are targeting underlying neurobiologic systems at the molecular, cellular, and circuit level that are responsible for dimensions of pathology like maladaptive exaggerated fear responses and or anhedonia that cut across different diagnoses. Our next question is, are there any safety considerations or potential risks associated with the use of psychedelics in therapy? specifically for trauma-related disorders, and how can they be managed? Very important question, because safety and tolerability is absolutely our first priority. Now, psychedelics, like anything else, have side effects. They could be transient gastrointestinal side effects or dizziness or headaches, things of that nature. One other type of side effect some people can experience is what's called a bad trip. In other words, people will have very unpleasant worsening of anxiety, worsening of their mood. Some people can have hallucinatory experiences that are really quite unpleasant. That can certainly happen for some people. Other safety concerns that we really need to get to the bottom of include, but are not limited to, things like the abuse liability. That surprises some people when I say that, because people say, I thought these drugs didn't have any abuse liability. Well, I think that's to be determined. What we can say is that the evidence we have now suggests that the abuse liability is very low, but we need to look at this very thoroughly. Secondly, what about the risk for flashbacks? Some people might be at risk of flashbacks, so-called HPPD, hallucinogen persisting perception disorder, as the DSM likes to call it. Well, we need to learn more about that, who's at risk, and what we can do to treat that if that happened, and how frequently does it occur. Thirdly, cardiovascular. Now, when we think about cardiovascular, I think about this, is it the electrocardiogram? No, so far the data suggests the electrocardiogram is not adversely affected. What about the cardiac valves? Well, we know that 5-HT2B agonists can result in cardiac valvulopathy. The serotonergic psychedelics and MDMA do have the ability to stimulate those cardiac valves. So far, this has not been looked at in any careful detail, and future studies will have to figure out what is the risk, if one exists. We don't even know if it even exists, but certainly in theory it exists. But what is the risk of any cardiac valvulopathy? So we do have some safety and tolerability concerns to be sorted out, and I think you're going to hear more about that over the next couple of years. Our next question is, how does the dosage administration and treatment protocols for psychedelic therapy vary for different indications, and what factors influence these decisions? This is such a forward-thinking question because at this point in time, this is still a work in progress, and that's my short answer. But the longer answer is that since the introduction of medicine back in the 1950s to treat depression and other conditions, we in psychiatry have embraced the so-called chronic dosing paradigm, where people take the medications every day. With psychedelics, there's the opportunity to have a more intermittent dosing paradigm. You don't need to take them every day. Of course, that would be wonderful if that's the case. Then the million-dollar question becomes, all right, if they don't need to be taken every day, is it once every week? Is it once a month? How frequently is it? And what should the dose be? What should the dose be when they're first being treated? Is that the same dose when they get a booster later on, or what have you? These are questions that need to be sorted out. And then the question also asks, is the frequency, is the interval different, is the dose different as a function of the diagnostic category? Again, that's work in progress. So we call these dose finding studies, dose interval studies, and these dose finding and dose interval studies across different diagnoses need to be looked at. But what we have right now in the literature is that most people are getting serotonergic psychedelics or MDMA 2 or 3 times, for example, over a period of, say, 1 to 3 months, but that's clearly not going to be sufficient for most people living with difficult-to-treat mental illnesses. Our next question is, are there any studies that have compared the effectiveness of psychedelic-assisted therapy versus EMDR for PTSD? I'm not aware of a study that's quite like that, but that study has to be done. And conceptually, there's something really, really, really important here. Comparing psychedelic-supported psychotherapy to psychotherapy alone will be conceptually interesting, because if in fact both treatments are effective, then that tells me we don't even need the psychedelic. If in fact it turns out that the psychedelic-supported therapy is better than the therapy, that tells me you're probably going to need both. And this is actually a question that some investigators around the world are looking at right now. In other words, does the combination offer a benefit over the monotherapy psychotherapy? It also is going to speak to something that's still also controversial in the field, and that is psychotherapy even required? We all agree patients who take serotonergic psychedelics and MDMA need support. They need psychoeducation. We all agree on that. But the question is not that. The question is, do they need protocolized psychotherapy? And frankly, the jury is out at this time. We just don't know. Our next question is, can MDMA, methylene dioxymethamphetamine, or esketamine, be used for refractory depression in the context of BP1, bipolar 1, or bipolar 2? You know, this is a question I love because I absolutely have arrived at the conclusion that bipolar is always the last one to get studied. And it's clearly something we have to really stop repeating. We obviously, bipolar 1 and bipolar 2 depression are very serious, very difficult, very impairing. And of course, we all know the morbidity and mortality. Right now, there are some data for esketamine in bipolar 1 and bipolar 2. It's called RWE, Real World Evidence Data. A colleague of ours from Italy has put a lot of patients with bipolar 1, bipolar 2 on esketamine, and has had some very safe and very effective outcomes. We've had a lot of experience with IV racemic ketamine in bipolar 1, bipolar 2. It's safe, it's well tolerated. We don't see a higher rate of dissociation, hypomania, or psychosis in people taking IV racemic when compared to adults with MDD. So far it's looking very safe. MDMA, in my own knowledge, has not been studied, to my knowledge, in bipolar 1 or bipolar 2 so far, but it is being studied in the future, along with serotonergic psychedelics. So we'll just have to wait and see what occurs. Most of the studies with MDMA have been in PTSD, and the second most common study diagnosis has been in the area of substance misuse. Okay, our next question. How do you design studies to assess the efficacy of psychedelics without breaking the blind? Wow, what a great question. This is something we've been anguishing about, because when you break the blind, you know what you're on, and of course that's going to affect the likelihood you're going to improve on the treatment. And when people know they're taking the drug, that tends to bode well for the drug. That's called an expectancy bias. And when they're of the belief system they didn't get the drug, that tends to really, in fact, reduce, if you will, the effect, and that could actually cause a nocebo phenomenon. So when we talk about breaking the blind, there's a couple of ways that we can try to preserve this. The most common way this is done is people take a psychedelic at a regular dose, say 25 milligrams of psilocybin, and then the control arm gets also psilocybin, but at what's called the subperceptual dose, so 10 or 1 milligrams. That way the person's getting an experience, but they're not getting the full trip. That's one way. Other types of drugs that are used to sort of give someone a sense they're taking a drug would be the use of amphetamine type or methylphenidates, benzodiazepines, niacin. They're not perfect, but this is other ways people do it. An interesting idea would be to give anesthesia to everybody, make them go to sleep, half get psychedelic and the other half doesn't. They get placebo, and you can look at the effect. That's pretty elegant in the sense, obviously everyone's blinded, they've been put to sleep. But the challenge with that is that's probably going to inflate the response for everybody. That's quite an intervention. That's probably going to increase the placebo effect anyways. And it's probably also going to be confounded by the potential antidepressant effects of anesthesia. And it's sometimes difficult given the duration of action of some psychedelics. So in short, this is something we're struggling with. And for now, where we've landed is using a subperceptual dose of some other psychedelic. Now, how frequently and what duration is psychotherapy-assisted psychotherapy needed to see results? Is there a limit? This is truly not known. At this point in time, it's not even yet established whether people taking psychedelics need psychotherapy. What they need is support and psychoeducation. But we're not even sure whether psychedelic treatment is assisting psychotherapy, or is the psychotherapy assisting the psychedelic? We don't even know. Given the name psychedelic-assisted psychotherapy, that obviously suggests that the psychedelic is catalyzing the effect of the therapy, which is where the real active ingredient is. That is a hypothesis. We don't even know if it's true. So because that's a hypothesis that might be true, might not be true, we're not even actually clear what the protocol should be. We don't have a standardized protocol. We don't know how many treatments, what's the limit, et cetera, et cetera. So this is still very much a work in progress. I'm glad the questions come up because it's important that we be very rigorous in how we are approaching these methodologies. And there has, in fact, been widespread acceptance of this moniker, psychedelic-assisted psychotherapy, but there hasn't been actually critical interrogation of, in fact, whether this is even required. Our next question, are there any studies showing maintained long-term improvement in symptoms following treatment with any of the psychedelics? Well, we do have some interesting data. There's some data in alcohol use disorder, some data in depression, some data in people with end-of-life depression, anxiety, more palliative or cancer-related palliative care situations, where they take a psychedelic and the benefit is sustained. And it's sustained for 6 to 12 months, along with alcohol and along with end-of-life depression. We've also seen some really intriguing data for tobacco use disorder, where people see a sustained benefit, that is staying away from cigarettes for 6 to 12 months out. So we have some data. They're mostly open label data. Nonetheless, the data are pretty intriguing actually and very interesting. What we absolutely need is long-term, adequately controlled studies to know whether or not the effect is sustained. When a patient acutely benefits and then open label, they're staying on the treatment, we know what they're on, and that does bias in favor of the drug. So stay tuned, but we do have some really promising data that for some of these psychedelics and for some diagnoses, we could see a sustained effect. Okay, here's a great question. Both ketamine and dextromethorphan are NMDA antagonists, and how and why are they different? Well, they're different in many ways. Well, one way they're different is, well, how they're typically given. I mean, ketamine is typically given as IV, although it can be given in other routes. Dextromethorphan has been combined with bupropion, a medication called Auvelity, which is an oral NMDA antagonist sigma-1 agonist. So that's the first way in which they're different. Another way in which they're different is, in fact, their bioavailability, their pharmacokinetics, generally speaking, is quite different. And their pharmacodynamics is similar, but a little different. In other words, they're both NMDA antagonists. Dextromethorphan may have a bit longer antagonistic effect at the receptor. Some people debate that, but there may be some differential effects at that receptor. What I might also say is that although they're both NMDA antagonists, keep in mind, drugs are like symphonies. They type a keyboard of neurotransmitters, and they have differential effects at different receptor systems that may also bestow upon the drug differential effect. Both have sigma-1 agonistic properties, but dextromethorphan is a very robust sigma-1 agonist, and we believe that not only modulates glutamate and monoamines, but may also modulate some of the inflammatory aspects, some of the insulin resistance, and oxidative stress. So dextromethorphan is a very interesting medicine alongside ketamine. Okay, here's the next question. Ketamine is being administered orally and as an intramuscular preparation in depression and PTSD. Can you comment on the modality of treatment? Be happy to. And you're absolutely right. That is certainly occurring in clinical practice. To step back 2 steps, most of the science with ketamine is in major depressive disorder, and most of it is given intravenously, not intramuscularly, and not orally. Just to put a little fine point on something, when you give a ketamine intravenously, the bioavailability approaches 100%. When you give it intramuscularly or subcutaneously, it approaches around, we'll say 90 to 95%. Orally is kind of more unpredictable. It's somewhere around 10 to 30%, and it can vary between and within individuals quite commonly. So oral clearly has a lower bioavailability. Now, people have been giving ketamine for depression orally and also giving it subcutaneously, intramuscularly, what I would say is the data are looking pretty promising, especially for oral and for subcutaneous. Obviously, people prefer to take a pill than have a needle, generally speaking, but the data taken together orally or subcutaneous is not as large in its body of literature, quantity and quality, as with IV. For PTSD, most literature in PTSD again has been with IV, but yes, you're right, we do have some data as well using oral and using the sub-Q or IM formulation, but it just isn't as much data. So in short, the best evidence in quantity and quality is IV. Oral is a bit unpredictable on the kinetic, but it is effective in some studies and, of course, easier to administer. And we also have the same set of qualifiers for PTSD. Okay. Thank you so much for all the questions. This has just been wonderful for me to speak to this exciting new psychopharmacologic frontier. One of the points I really pressed here at Congress this year, NEI in Colorado Springs, is we need hope. We need new treatments. The new frontier is exciting, but we also need to have thorough, rigorous, adequate, controlled studies really trying to carefully characterize the tolerability and safety and the efficacy. We hope that with serotonergic psychedelics and or MDMA, we get to a point that we've seen with ketamine and esketamine, wherein we've been able to offer treatments that have really improved the quality of people's lives. So thank you so much. I hope these answers prove helpful to your practice, and thanks for making this so enjoyable for me.
Thank you for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.